Good morning and good afternoon and good evening to all of you. Thank you for attending today's briefing. I'm Liz Helms, co-founder and director of the Chronic Care Policy Alliance, which I will talk about more in a moment. We are so delighted that so many of you could join us today. It exemplifies the need for this information. So welcome. Next. I wanted to give you a brief overview of what you're going to see today, do some housekeeping, and answer questions ahead of time about the availability of recordings and downloads and things like that. So today's overview is of the CDC and practice perspectives. We received hundreds of questions. So we've selected questions and we'll be answering as many of those that we can. Additional answers to your questions will be found on a special page on our Chronic Care Alliance webinar page, which you can see on this slide. If you need to talk to us, please connect us via the chat or raise your hand. Unfortunately, any questions today that come in through the chat box will be added to our list of questions. We appreciate every single question and we want to get back to all those questions as soon as we can. So those questions will be listed on our website. A copy of this presentation will be available to download at www.chroniccarealliance.org/webinar. This briefing is being recorded and a link will be sent to you. With all of our speakers, there are no disclosures. Next. So I want to give you a little bit of background on who the Chronic Care Policy Alliance is. We're a network of state and regional health advocacy organizations advancing public policy that improves the lives of those living with chronic conditions and diseases. Our advisors are wonderful and thoughtful, and volunteer advisors make up the Arthritis Foundation with Ben Chanock out of Washington, D.C., with Joan Werbland, our full-time volunteer from the California Chronic Care Coalition based in Sacramento, California. To the Colorado Chronic Care Collaborative, Sharon O'Hara and Sarah Froelich out of Denver, Colorado. To Rolf Benershka out of San Diego, California with the Grateful Patient Project, Legacy Health Strategies, and many other great works that Rolf works on. And to Tom McCoy from the Nevada Chronic Care Collaborative. Thank all of you for being our great advisors and being here with us today. Next slide. Co-hosting today's briefing include the Global Healthy Living Foundation and the Asthma and Allergy Network. So I'd like to briefly introduce you to Shubha Venkateshwaram and Tanya Winters. Both of them have spent so much time planning this meeting, and I appreciate you so much and welcome you to this briefing. Next slide. I also want to take a minute to talk about all of our hosting and co-sponsors representing over 67 organizations. We cannot thank you enough. Today, there are 2,100 attendees on this call representing all 50 states. Additionally, we have participants from Puerto Rico, Canada, Ireland, and Italy. We will add other countries in our meeting recap that will be found on our CCPA website. Our attendees represent physicians representing rheumatology, pulmonology, cardiology, family practice, oncology, provider organizations, also including pharmacists, nursing, academics, health plans, first responders, and people on the front lines. We can't thank you guys enough. Caregivers, public health agencies from all over the country have joined us, and our wonderful nonprofit grassroots and public policy advocates that tweeted and shared and stayed engaged to make this all possible. We are better together and we will persevere. Next slide. This is a little overview of what the agenda looks like. I'm going to let Dr. Balmer, I'm going to introduce Dr. Balmer in just a minute and turn this over to him. But this is the overview. What we're going to try to do is have our three expert physicians go through their slide deck, and then we're going to go into questions, and you'll see all the questions that we have, and there's so many more that we would like to address, but many of them were very similar. So we put those together. So hopefully your questions will be answered. And on top of that, the questions that you're asking are also going to be addressed in many of the slide presentations that you'll see today. Next. Now it is with great pleasure that I introduce Dr. William Balmer. He's the chairman of the Right Care Initiative Capital Region University of Best Practices, Executive Committee of the American College of Cardiology, California chapter, professor of the Division of Cardiovascular Medicine, University of California, Davis, and currently serves on the CDC's Hypertension Control Work Group. Dr. Balmer's service to the American College of Cardiology includes his current role on the California Executive Committee, as well as former roles as president, vice president, governor, and member of the Board of Governors. As an accomplished UC Davis clinical professor of medicine, he directs UC Davis Cardiology's non-invasive services, directs the Cardiology Fellowship Training Program, and sees patients in the CCU. He's a very, very busy man. As the longest tenured UCD training director, he's trained over 200 practicing cardiologists. Dr. Balmer has been the principal investigator or co-investigator of multiple NIH, NHLBI, and international research trials. He's a member of 50 international, national, state, and university education commissions and committees. Please welcome Dr. Balmer. Dr. Balmer, it's all yours. And you just need to unmute.
Good morning, afternoon, and evening. Can everyone hear me?
Yes.
Next slide, please. Well, I want to welcome everyone to today's program, no matter what time it is in your time zone. We have a great program today, and we're going to feature Dr. Georgina Peacock, who will be speaking. She's the Director of Human Service, Human Development, and Disability as part of the Centers for Disease Control and Prevention, and is dedicated to health and development of children and adults, their diseases and health across their lifespan. Also, Dr. Vikram Tejwani, who is from Johns Hopkins University, specializing in pulmonary medicine right now at Johns Hopkins, having arrived from Cleveland Clinic, treating chronic lung disease in hospitalized patients, and recently serving at the front lines for COVID-19 in the Johns Hopkins ICU. Next slide. So we will be going over a couple things related to COVID-19 and chronic disease community for this briefing. Next slide. So we had a couple of questions that came in initially that we wanted to at least consider. First of all, what makes an additional high risk for coronavirus complications? What makes an individual with chronic disease high risk? And we'll be going over that, and what you can see on the slide on the top is that individuals who present with hypertension, obesity, diabetes, cardiovascular disease, or chronic lung disease have an increased risk of actually acquiring COVID-19, have an increased risk of requiring hospitalization for the treatment of it, an increased risk of being in the hospital and then going to an intensive care unit because of severity of the disease. And on the slide on the bottom, you can see that in addition to being more likely intensively treated in an acute care area, they're less likely to survive and almost double the rate of mortality in individuals who, in fact, have hypertension, diabetes, coronary artery disease, or chronic lung disease. So why does COVID-19 increase our risk of acquiring the disease and increase the severity of the disease in us? It makes it more likely that we'll go to intensive care, get intubated or on a mechanical ventilator, and more likely to die. And we'll discuss that today. Next slide. So what are some of the things people can do with chronic disease to protect themselves? Well, if we look at this slide, we see in the center is a diagram of the COVID-19 or the SARS-CoV-2 virus. You can see it's a virus that has little spikes attached to it, and at the bottom is the host cell. Now you can see there's a direct attachment that can occur between the spike on the protein virus and the angiotensin receptor that is located on the cell. This shows the attachment that needs to be activated. The reason I show this is what can prevent that. Well, first of all, you can see that this attachment requires close proximity to the cell. In fact, it has to be much less than a micron in distance between the virus and the cell. Therefore, if we can separate the virus from our susceptible cells, then that's probably one of the best ways we can use to protect ourselves. So you've all heard about 6 feet distancing. As long as this virus does not attach itself closely to one of our cells, we would be protected from it. This virus, as you can see, does not have wings. It does not have flippers. It can't swim or fly to us. It has to get to us by either droplet or by us picking up contact and then rubbing our eyes or nose or mouth and conveying it directly to our cells. So if we can keep a separation from this virus, we can protect ourselves, and that's one of the most important things we'll discuss today for people with chronic conditions. Maintain separation and distancing from individuals who might be at risk for this. Next slide. Now, what are some of the treatment options for people? Well, we mentioned earlier at the top that this is a very sensitive virus. It is a virus that has a very thin wall that dries out easily in contact with high temperatures or ultraviolet or many agents, including all soaps and shampoos and things that would contain high levels of alcohol, so that we can see that this is an easily destroyed virus if it is not allowed to come in contact with us first. So if we can increase the heat on it, allow it to dry out, and avoid touching surfaces for a period of time, we can certainly protect ourselves from the environment, and any soaps or alcohol or sterilizing solutions would be enough to kill this very fragile virus. So attacking it is a good way to protect us. If we look on the bottom slide, once you have contacted the virus and contracted it, then it's too late to do separation and sterilization. We now have to address the fact that the SARS-CoV virus is now in your cells at this time. And what we see on the bottom is there are 7 steps for this SARS-CoV virus seen to enter the cell. First, contact, enter the cell, and then disperse its information into the cell and turn the cell on to manufacturing the proteins that it needs to replicate. That replication process, proteins are generated, and then in the inside of the cell, there's an assembly factory that is set up to repackage the proteins that have just been made for this virus and to then deliver this package to the outside of the cell where it can do more harm. So we can see that there are literally 7 areas where antiviral treatment will be or could be effective in preventing the replication and manufacture of this virus in our cells. Remember that the virus we contact above from someone else is a small number of units, so small that it won't cause us severe harm. It's the fact that these viruses, once they get into our cells and our cells start manufacturing billions of these viruses, that's what gets us into trouble. So our own cell manufacture of these excessive viruses in the billions is what leads to difficulty and problems that occur 5 to 10 days after encountering this virus. But the good news is it's a very fragile virus. And the other thing is we have at least 7 targets we can look at for interrupting the replication of this virus in our cells. Next slide. So if you're a high-risk individual and you contract the disease or contact the disease, what should you do? Well, you need to monitor yourself for symptoms seen on the left. And this virus affects many areas of the body, so many symptoms can be seen. In addition to common cold, it is similar to common cold when it starts. It develops early on. Pulmonary involvement and GI involvement is common as well. Fever is common as well. So we need to, in fact, monitor yourself if you develop any of these symptoms. And if you develop a fever, you want to contact your healthcare provider at that time and ask their advice. Every one of you has a different personal medical history, and the recommendations for each of you would be different in that case. The SARS-CoV-2 virus on the right can affect the brain, the heart, the lungs, the liver, the GI tract, the kidneys, and the rest of the body. So it involves literally all of those areas where it can enter the cells through a receptor. And it also turns on an immune system that can also affect each of those organ systems as well. So if you're high risk and you get any of these symptoms or fever, you should contact your healthcare provider for further specific recommendations for you. Those recommendations might be to just monitor temperature, or it might be to go directly to an emergency room because you're high enough risk that we need to see you right away. Next slide. What does it mean to safely resume? We're all looking forward to the reopening of the society and economy so we can do things. That's going to depend on location of where you are. Shown on the upper left are the recommendations of the state of California by the governor, and it requires for opening up the society that we in fact have the ability to in fact protect high-risk groups, including people with chronic disease. Realize that individuals with existing chronic disease, because they're at higher risk of acquiring and having complications and dying of this disease, need to be especially protected. Their risk may be as much as tenfold higher than the risk of another healthy individual. So we have to take that into account and protect them as well. In addition to that, we have to have ways of, in fact, moving to the next stage from mitigation, where we are now to try to separate everyone, to actually being able to track cases, and we need to test to do that. So we have to wait for the ability of hospitals to, in fact, be able to treat a surge of patients, and we have to be able to track patients and have better testing that's available. In addition, to be safe for people with chronic disease, we need to know that there is some better not only testing, but treatment for this disease. So at the bottom, we've got standard of care, and I've got a variety of treatments that have been used for individuals with active COVID-19 virus. Not all of those are fully tested. Not all of those are recommended at this time. They are protocols that are under study at this time. So until we have recognized an effective and safe treatment for this, we can't really treat individuals who escape vaccinations for that. Vaccination is an ultimate recommendation that we would like to get to. We are probably at least 6 months to a year and a half away from that at this point in time. Once we have vaccinations, though, we know with the influenza, not all people are protected, so we do need to have treatment. So for those at high risk with chronic disease, we need to wait until we do have a vaccination process and a standard of care or treatment of people with active disease before it will truly be reasonably safe for them to resume everyday activities. Next slide. And lastly, what is the status of testing? It's required to move to the next stage of reopening for society. And so testing is very important. The testing varies based on what your location is. I'm showing you the testing that is done at UC Davis at our health center. And we are able to do about 2,000 tests for the virus each day in an automated protocol at this time, and about 700 tests a day for the serology testing for individuals who would be potentially immune to the disease at this time. So this sounds like a great number of tests, but there are millions of tests or millions of patients who may require this in the future, 300 million, and how often do we have to test them? Clearly, we're going to have to go a long way to, in fact, improve our capability of testing as we move into the next stage of reopening of society. Next slide. So with that, I'm privileged to introduce Georgina Peacock, who we introduced before as the co-lead of the Community and At-Risk Task Force for the Center for Disease Control and Prevention, importantly. And so I'd like Georgina to tell us a little bit about coronavirus and the at-risk groups that they're encountering.
Hi, thank you, Dr. Baumer. Thank you for including me today. And I first wanted to start by acknowledging people's anxiety and how extraordinarily stressful it is at this time, especially for people who may be at higher risk for severe illness. So I'm hopeful that what I share today and what we hear from the other experts on this webinar will be of help to you all. Next slide. I wanted to start out by sharing some background information on coronavirus, and you did hear a little bit from Dr. Baumer, but I'm going to share some as well. Next slide. So coronavirus is a large family of viruses that cause respiratory illnesses, and the first was identified in the 1960s. It's named for the crown-like spikes that are on the surface, and these viruses can spread among animals and people, and so we call it a zoonotic virus. As of note, there are 7 human coronaviruses now, which include the SARS-CoV-2, which is this virus that we know causes the disease COVID-19. And just for a bit of trivia, if you wondered how people came up with the word COVID-19, the CO stands for corona, the VI for virus, the D for disease, and the 19 because it was first observed in 2019. Next slide. So as I said, it was identified in December of 2019 in Wuhan, China, and as a reminder is caused by the virus SARS-CoV-2. And early on, many patients were reported to have a link to a large seafood or live animal market. And then later, patients did not have exposure to animal markets. And this was what indicated to us that there was person-to-person spread. So the first travel-related exportation of cases to the United States occurred January 21st of 2020. And I list here the website where CDC reports the different cases of COVID-19 and the numbers, and that is something that is updated every day with a lot of different information. So you can go in and see number of cases, you can go in and see some of the racial ethnic distribution, you can see number of hospitalizations and other things, and where there's a lot of spread within the country, so you can see the differences in the country. Next slide. So this virus is thought to spread mainly from person to person, as I said, between people who are close in contact, so within about 6 feet of one another, through, as we heard earlier, respiratory droplets that are produced when an infected person coughs or sneezes. These droplets then land on the mouths or nose of people and are of people who are nearby, and then are possibly inhaled into the lungs. And recent studies have suggested that COVID-19 may be spread by people who are not showing symptoms. Next slide. So this slide reminds us of the different symptoms that someone may exhibit if they are symptomatic. So fever, cough, shortness of breath or difficulty breathing, chills, repeated shaking with chills, muscle pain, headache, sore throat, and a new loss of taste or smell. We believe that the estimated incubation period is between 2 to 14 days. So from that time that you're exposed, you may develop symptoms on day 2, or it may take up to 14 days. There is a wide range of severity of illness. It can be very mild to very severe, and as you know, can result in death. And when there are complications, this usually includes, or could include, pneumonia, respiratory failure, and multi-system organ failure. The emergency warning signs for COVID-19, where you should get medical attention immediately, include things like trouble breathing, persistent pain or pressure in the chest, new confusion or the inability to arouse the person who is ill, or bluish lips or face. Next slide. And these are just reminders. I think it's good for all of us to get the reminders that the best way we can avoid severe illness from COVID-19 is by preventing getting it. And so cleaning your hands often with soap and water for at least 20 seconds. That's about the time it takes to sing the Happy Birthday song twice. You can also use hand sanitizer that contains at least 60% alcohol. Avoiding close contact with people who are sick, staying home as much as possible, and putting 6 feet between yourself and others. Covering your mouth or nose with a cloth face covering when around others, and remembering to wash that face covering regularly. Covering cough and sneezes, and then cleaning and disinfecting frequently touched surfaces regularly. Next slide. So now that I have shared some information on coronavirus generally, I'd like to talk about some of the work that we've been doing within the task force that I've been leading. So while I usually work as a division director for human development and disability, for the last couple of months I've been leading a task force within the COVID-19 response at CDC that's focused on community and at-risk populations. Next slide. And our aim is to reduce morbidity and mortality for those at risk by focusing on 3 categories of work. Those people who are at risk for severe illness from COVID-19, which I'll discuss over the next few slides, but include older adults, those 65 years and older, and those with varying underlying medical conditions. We also focus on populations with different access, functional, or communication needs. These may include racial and ethnic minorities, people experiencing homelessness, people with disabilities, those who may have low literacy or need to get communication in different ways. For example, we have developed a number of American Sign Language videos to assist those who use that language. And then we also have a group that focuses on social behavioral health and emotional well-being. Certainly mental health, coping and resilience, as well as are important to focus on. And we also have been monitoring intimate partner and domestic violence, suicide, substance use disorders, and things like that, because we are seeing as this pandemic continues that this is placing many stresses on many parts of society, and we're seeing a lot of these sort of secondary effects. And then finally, within the focus of our task force, we are looking at different settings where people spend their time. So homes, schools, childcare programs, retirement communities, faith-based organizations, homeless shelters, correctional facilities, colleges and universities, and then providing guidance for how to minimize spread in these types of settings as the pandemic continues. The next slide. So the way we do this work is by looking at the epidemiology, looking at the data that tells us who's at greatest risk and other factors for concern. Then we also are monitoring. So when we make recommendations related to intervention in communities, we then are looking at how effective those are and then changing guidance depending on what we're finding. We spend a lot of time providing technical assistance. For example, this morning I was on, and last night was on calls with people concerned about homeless shelters and providing information on how testing could be helpful, when that should be done, and sort of talking with teams on the ground to help implement some of the guidance that is out there. And then we do a lot of communication, developing tools that you may see on the CDC website. We've done a lot of work working with different social media platforms in order to get messages out, and then through partnerships like the one here today, so that we can talk with different groups who may have questions about COVID-19. Next slide. So more information on those who are at higher risk for severe illness. So based on, so COVID-19 is a new disease, and so there's limited information regarding risk factors for severe disease. But based on the current information that we have, we believe that this list includes people 65 years and older, people living in a nursing home or long-term care facility, and people of all ages with certain underlying medical conditions, particularly if it's not well controlled, such as people with chronic lung disease or moderate to severe asthma, people with serious heart conditions, people with severe obesity, so a body mass index of greater than 40, people with diabetes, people with chronic kidney disease undergoing dialysis, people with liver disease, and those who are immunocompromised. Next slide. So in that group of those who are immunocompromised, this includes people undergoing cancer treatment, those who smoke regularly, bone marrow or organ transplantation, immunodeficiencies, poorly controlled HIV, and the prolonged use of corticosteroids or other immune-weakening medications. And of note here, we have received a number of questions related to whether inhaled steroids for asthma should be continued, and absolutely those should definitely be continued, as well as any other medication that's prescribed by a physician or medical provider. It's really important that people do pay attention to their medication unless they talk to their doctor. So the next slide, I'm going to go into a little more detail on the study that Dr. Balmer talked about at the beginning, which was a CDC MMWR that was released April 8th of 2020, which looked at hospitals.
We have lost Dr. Peacock's audio. In the meantime, we can see that this confirms this slide that individuals over 65 years of age, as I showed, have a higher risk of both acquiring the disease and having a complication from the disease and dying of the disease. And it certainly is also present in those with underlying conditions such as hypertension, obesity, chronic lung disease, diabetes, and cardiovascular disease. And I think in the question period, we are going to explore a little bit, why is it that people with existing cardiovascular disease are at higher risk for acquiring it and developing a complication and death from that? So what do we do for people with existing cardiovascular disease? Well, literally, if you look at the Johns Hopkins numbers, about 1 million people in the US have currently tested positive for COVID out of the 300 or more million people that we have. So it's not everyone. Your chance of having COVID right now is about maybe 1 or 2% of actually having the active disease. It's a little higher in epidemic areas like New York City, where it's as high as 20% of the population were exposed to it. But the majority of people who have existing cardiovascular disease don't actually have it now. And we want you to continue your medications at this time. So don't stop your medicines. We have no evidence that stopping your medicines, even if it's an ACE inhibitor or an AR blocker for blood pressure, would in fact benefit you. In fact, we're at risk, if you stop your medicines, of then developing the typical garden variety cardiovascular disease of heart attacks, strokes, and heart failure. So do not stop your medicine without talking to your physician, and we do not recommend that you stop anything at this time. Let's go on to our pulmonary specialist, Vikram Tejwani, and I've introduced you to before, so welcome, and you're on the front lines of taking care of these COVID patients. Once they get to the hospital, they often get to the ICU, they get on mechanical ventilation, and you're responsible for, in fact, treating them at that time and helping to have them achieve recovery and discharge from the hospital. So Vikram, go ahead.
Great. Hello, thank you, everyone. And I just want to thank Liz, the California Chronic Care Coalition, Global Healthy Living Foundation, and Allergy and Asthma Network as well for inviting me to speak in this important forum. So as mentioned, my name is Vikram Tejwani. I'm a lung and ICU doctor at Johns Hopkins. I, prior to this, spent the majority of my time treating patients in clinic with chronic lung disease and intermittently being in the intensive care unit. And then more recently have been, as Dr. Balmer pointed out, in the COVID intensive care unit, which I'll actually be returning to our COVID ICU on Sunday. I'm here today to discuss the implications of this disease for those, particularly with chronic lung disease, and how to navigate this. So if we could go to next slide. Broadly speaking, there are three major implications, one which is well publicized, I think, in the media, and one that has been discussed and I will delve into as well, is that chronic lung disease confers a higher risk of more severe disease or being hospitalized. Two is that systemic treatment or pills for these diseases can cause immunosuppression. Specifically, this pertains to medications like prednisone or other steroids for a long duration, hydroxychloroquine, which I know many questions came in regarding mycophenolate. And I do just want to echo and reiterate what Dr. Peacock pointed out, which is, one, inhaled medications, including inhaled steroids, do not qualify as immune suppression. And two, for most conditions, that risk is actually something that existed pre-COVID and should not be discontinued at this time without discussing with your doctor in the context of your own situation. The third broad implication, and one that I want to highlight, because I think it's not reported or not recognized as much, is for many people with chronic conditions, access to healthcare before all this was kind of right on the cusp of being able to get the appointments you need and the tests you need and the time needed. And now there's been a huge allocation of these resources to a disease that really didn't exist 4 or 5 months ago. So I think that's important and is worth highlighting just because it's not something that's discussed as much. In our own personal practice, we're now seeing patients with telehealth visits, are not doing pulmonary function tests or breathing tests. And of course, there's a whole array of quote unquote elective surgeries and procedures that are being deferred. If you'd go to next slide. Before delving into how best to navigate this, I wanted to briefly review a couple of important reports, one related to asymptomatic cases, and then a more recent report of hospitalized patients from New York to go over some of the characteristics of people that are being hospitalized. As you all have heard, this is it's a new disease. We're kind of figuring it out as it's evolving. And one thing that's become apparent with actually at least 3 reports is that there are a number of patients that are testing positive that are screened for reasons and are asymptomatic. An example of this is given on the pie chart on the right. This is from 215 pregnant women that came into their office to see their OB doctor for delivery in New York, and about 15% were positive, so the vast majority were negative. And of those 15%, only a couple of them, specifically 4 patients, had symptoms. So that means 29 of these 33 women that tested positive were walking around with this in their their nose, the lining of their nose, likely sneezing and coughing it, aerosolizing it, and were exhibiting no symptoms at all. This has been so that's about 87% that were asymptomatic. This has been reproduced in a prison population. There was an outbreak amongst inmates. All were tested, and about 80+% were asymptomatic. This is with the important caveat that these are typically otherwise healthy individuals. A similar study was done in the nursing home, one of the nursing homes in Washington, and 50% there, which is a more chronically ill population, was also positive and asymptomatic. So if we could go to next slide. So what we're looking at here now is that, and I just kind of want to contextualize this, is we have the broad number of patients that contract coronavirus or would test positive, a much smaller percentage that are symptomatic, and then an even smaller percentage that are hospitalized. This is a report similar to that report that Dr. Bomber and Peacock showed on hospitalized patients. It was published about 6 days ago, or 7 days ago now, and it was on 5,700 consecutively hospitalized patients. And again, what we're seeing is that high blood pressure, obesity, and diabetes are the most common coexisting conditions, and generally hospitalized patients skew toward the older side. One thing to note is that 9% had asthma and about 5% had COPD. If you just took a random subset of the American population, that number would be about 7 to 8% for asthma and 4 to 5% of COPD. So definitely still a higher risk for these patients, but not as much as actually high blood pressure and obesity in particular starting to come out as a common vein in the reports that we're seeing. I didn't show this here, but there was another study from China where they tried to show what actually predicts likelihood of dying, not just getting hospitalized, and that the strongest signal was for being over 65, heart disease, which is specifically coronary disease, or a pre-existing stroke. If we could go to next slide. I'll try to end on this slide before transitioning over to the Q&A. But basically what this all means and how to navigate this, one is continue all the CDC recommended precautions. The second point I think is one that hopefully the data has exemplified, that the absence of symptoms does not, excuse me, equate to being non-infectious. And that's quite distinct from the flu and other infectious diseases where somebody has infection, or excuse me, a cough, fever, chills right away, and you know to stay away from that person. This is actually very good for the virus in a way because it allows it to spread, but it makes us navigating it much more challenging. Ensuring that there's a plan with your providers, doctors, and otherwise of your chronic conditions for a continued management, and making sure that that care doesn't fall through the cracks. Continuing to follow what's coming out as far as testing and treatment. And then lastly, and I'll close on this point, just particularly note that this is a stressful situation across the board, and ensuring what this means for you to emphasize that your psychological well-being is being addressed as well. I'll end there, and I think we can transition to the Q&A session.
Thank you very much. Let's proceed to the questions and answers program. We had some general topics that we were going to discuss that we've sort of covered, and let me ask Vikram if he had any comments on the general questions which related to protection of individuals and treatment options. Are there treatment options that you think are in fact positive enough that we could mention them for the patients who get into the ICU who are in fact severely sick? Is there anything that you think is there, or are we still waiting for an appropriate treatment for the hospitalized intensive care unit and ventilated COVID patient?
Yeah, I think that's a really wonderful question. Interestingly, the most powerful intervention so far, and I think I've seen some articles in the media about this as well, is actually just proning someone, which is essentially what putting someone on their stomach rather than their back. That has some complex physiologic changes with the way blood and air goes in and out of the lungs. Typically, we've reserved that for patients that are on a ventilator and have become very sick and we're having challenges. One of the changes in our practice, and we're studying this as well, is to actually do it much earlier, excuse me, and to use it in a way to prevent a breathing tube or a ventilator from being needed. As far as the medications, there was actually a report, an early report that I haven't fully delved into for remdesivir this morning, and I think we also are looking at plasma from patients that have recovered. I think the short answer to treatment is we don't have anything that would meet a rigorous scientific standard yet, but I do think there's a reason for hope as far as medication intervention. And then again, in the meantime, we have something as simple as just lying on our stomach.
So we have some patients who are worried about going to an ICU, getting intubated and on a ventilator. Would that increase their risk or decrease their risk? Obviously, we are using low volume ventilation to try to improve that, the proning that you mentioned above, and we're putting them on some antibiotics because of the possibility of additional infections with bacteria as well. Is there a risk of actually putting somebody on a ventilator? Should we consider earlier transfer to ICU and ventilator for our chronic disease populations?
Yeah, that's a wonderful question as well, and a little bit of a moving target regarding when to ventilate. There are some other ventilatory strategies without a breathing tube that people with sleep apnea may be aware of, like CPAP, and there are other masks we have like that. Unfortunately, there's at least a risk theoretically that using those in patients with COVID can aerosolize the virus, which has a whole nother set of implications. So our practice generally has been to err on side of earlier mechanical ventilation. I think early transfer to ICU is definitely appropriate, and then based on when exactly to go on mechanical ventilation, it's still at this point a little bit of a case-by-case approach.
Great. And I've got a question here that is, why do you have those with chronic disease, hypertension, diabetes, more likely to, in fact, develop a complication and die if you get COVID disease? If we could move to the slide I added for Q&A. So we do know that even though COVID-19 primarily affects or is in contact with the lungs, that there's a significant amount of cardiac involvement in those individuals. And we know that individuals who get cardiac injury, as reflected by an enzyme, troponin, or a part of the muscle that is high, have as high as an 80-fold increased chance of dying from this disease. In fact, those with high levels of troponin, which is a cardiac injury marker, are associated with a 70 or 80% mortality in the hospital. Why is that? Well, COVID-19 has the ability to interact with a couple of things in the heart and cardiovascular system, including it may have direct ramifications on the ACE2. We mentioned earlier the ACE2 receptor on the cell wall is what the spike protein attaches to get entry into the wall or into the cell of the host system. So there's a direct interaction there, and it also upregulates the angiotensin system to create higher levels of blood pressure. Those may lead to increased problems of vascular ability in the individual. Those who have pulmonary infections also have low oxygen, as we mentioned. They're on ventilators to try to get it higher, but low oxygen can create stress in the blood vessels and in the cells of the heart as well, and produce extra strain on the right ventricle, which may fail at that time. And there is also evidence that there is microvascular damage in the blood vessels of the heart and of the lungs as well. We know that there's an increased coagulation or blood clot if you in fact have if you have COVID-19. And because there's increased coagulation at that point in time, many of the small vessels, microvessels, may get blood clots, and that may actually lead to injury in the heart. And if that is present, that will increase your chance of not surviving your hospitalization in an intensive care unit. And lastly, the COVID virus will induce an inflammatory response by our immune system. And if the immune system overreacts, it can actually create a lot of inflammatory proteins that go around the body, creating inflammation everywhere that can lead to damage or attack of other cells in our body. So that inflammation can be counterproductive at that time and actually lead to further injury. So coagulation problems, inflammation problems, hypoxia problems, and interruption of the normal reflexes monitoring our blood pressure and vascular tone are all areas that COVID-19 directly affects people with pre-existing cardiovascular disease, including hypertension, diabetes, and obesity, and may likely explain why these people do poorly and die. Next slide. Let's go back to the question.
Thank you.
Yes.
We have
Dr. Peacock.
Peacock.
Yeah, I'm
So-
here. Sorry, I could hear you the whole time, but you couldn't hear me. I don't know why.
Well, welcome. And do you want to address the 3 or 4 slides you missed, or do you want to go through the questions?
Why don't we do the questions? I think that you covered the end of my slides quite nicely. So
Okay, so you're up for the next question, which is in individuals who have juvenile arthritis or other diseases where there's a hyperactive immune system. They are frequently on therapy to reduce their immune response, corticosteroids, biologics, etc. How are those individuals at higher risk for getting COVID-19? And if they do, what do they do with their medications?
So I don't know that we know that if they're at higher risk for getting COVID-19, but we do know that they're at higher risk for severe illness from COVID-19 because they are on a medication that weakens the immune system. I do see that it also says in this question, it's suggesting that this particular scenario is in a child. And interestingly, we have not seen as much severe illness in children. So I think it's important to think about these different underlying conditions and age on a continuum. And it appears that if you have more underlying conditions or if you're older, you tend to have more severe outcomes for COVID-19. So I think if a child had, say, juvenile arthritis and was on a biologic, they may be at some increased risk, but maybe not as much of an increased risk as an adult that might have arthritis and be on biologics, or if they had other multiple underlying conditions.
Thank you, thank you. Our next question, Vikram, we've heard a lot in the press about hydroxychloroquine and chloroquine and its use. Obviously, it's being used in medical illnesses. Does this play a part in patients with COVID-19?
Yeah, that's a good question. I'm glad to discuss it because, as you said, it's been so prevalent in the press. I think the short answer for hydroxychloroquine is no, it doesn't play a role. There was a lot of early interest, and I should note that all of that early interest was just based on tests that said it made somebody's nose swab have less virus than it did a week ago. There was no translation into, oh, it actually made somebody clinically do better with the treatment. Since that time, and I think early on there was a lot of interest in it, there have been more definitive studies, and at least as of right now, it's pretty clear that the risks of arrhythmias and other abnormal heart rhythms outweigh any benefit that it may have. So I know a number of questions I think from our attendees were centered around that. I'm optimistic that as that continues, that those negative results continue to be disseminated through the medical community, that the prescription of it for COVID goes down, and people that are on it for their regular chronic conditions will not run into supply side issues.
Great. And there's one more question for you. If you go on a ventilator, what's the chance of getting a patient off a ventilator and being discharged from the hospital?
Yes. So the best data we have on that is from that same study in New York of 5,700 patients. And this is really important because they initially actually, I won't get into the nuance of it, but epidemiologically or statistically did something incorrect and had a report of 88% death when being put on a ventilator. And that number is striking, frightening to anybody, and made its way into the media. They since issued an amendment to that, and it was a 25% rate of death. That's still high, but it certainly does not equate being put on a ventilator with no likelihood of recovery. That still means more than half. So 3 or 4 patients are making it off the ventilator and out of the hospital eventually.
Thank you. Georgina, for someone who has had COVID, been in the hospital or not, and recovered from it, is there any long-term data that might affect either their pulmonary or their cardiac function months down the line? Is there any residual disease that we will be encountering in those populations?
You know, I think we don't know that yet. I mean, there's a lot to learn. This is a new disease, and we definitely are working here at CDC, but also with clinical partners and academic partners to try to figure out what the course of COVID-19 is. But I don't have the answer to that right now. We need to continue to learn. Maybe you all who take care of patients sort of have daily may have some anecdotal thoughts on this.
So a question for all of us is going to be, which is important, is when will the vaccine be available? Does anyone have information on that?
I think no more than anyone else.
Right, I think that
Been educated. Yeah.
we are all in a period of time of evolution. We
Mm.
have actually developed several vaccines for viruses in the past through our laboratory here at UC Davis. And we're clearly, we received the first community acquired patient back on February 19th, and we took the virus from that patient and we actually have used it to initiate a vaccine, but we're far away from actually developing or refining that vaccine. A vaccine just doesn't mean you inject anything. It has to be delivered in the proper way. And we're looking for vaccines that would be neutralizing the virus before they got into the pulmonary cells at that time. So if we can get one that neutralizes it before it's inside the cell and replicating, that would have an advantage, but we're still working on that. And as I say, we are 6 months to 18 months away from that at this time.
And then just, I'm sorry to interject, but for the last question, it's not specific to coronavirus, but we do know that just patients that are in an ICU and are there for a long period of time, and I will say this particular virus does seem to be a longer disease than the seasonal flu. So patients are on that do need a breathing tube and mechanical ventilation are on it for a longer period of time. So there is a lot of just recovery from that long of an ICU stay. There's actually a disease process called post-ICU syndrome, and that's associated with weakness, fatigue, sometimes not being as mentally sharp as you were. That's not necessarily unique to this particular virus, but it's just something that can occur with more and more days in the ICU and on a breathing tube.
Yeah, I agree. And I think what we've seen is people who go on a ventilator longer.
Mm-hmm.
And because they have frequently more restrictive disease, then there's a question of will fibrosis play a part in these people long term after recovery from a pneumonia from COVID-19. So yes, I think it's uncharted territory, and we still have to see whether there will be a post-COVID syndrome that we have to deal with for that. We've addressed the hydroxychloroquine, so let's move to the next set of slides for questions. So Dr. Peacock, you mentioned that it's your task force to develop ways of supporting people with disabilities, no matter what they are. So how have you, in fact, addressed that? And is there any hope for these individuals, especially people who, as you said, are homeless, don't have access to care, or have disabilities already? How are you addressing those communities?
And Dr. Bauer, I believe that Dr. Peacock had to leave to get to another meeting. So we can move on.
I think she talked about that a little bit. That's clearly what we need to do. Hopefully the second time around we'll do a better job than we did the first time in our reaction to COVID-19, and we are learning a lot. So hopefully we'll be a little bit better prepared. We anticipate that there may be a second wave of COVID-19 after this first this first peak is flattened out at that point in time. So I was going to have her address isolationism because she was going to talk about that. That's clearly an issue for everyone in the world today who is in fact isolated from physical contact or close proximity to their friends, family, and needed people. So we do have an emotional area that needs to be addressed as well for that. So one of the questions that we have is we are changing our healthcare to telemedicine at this point in time. And I anticipate that will be available and better prepared for the next round when we go forward for that. So we should be able to see that. Let me ask or address Vikram if a single mask, surgical mask, or an N95 is better for you if you're walking around running, or is just 6 feet away going to be enough when we resume our activities in the community?
Yeah, that's I think a really important practical question. So the 6 feet definitely covers breathing. There's been some studies where they've looked at people coughing or sneezing, and it does seem that that can actually go even a little bit longer. Let's see. So I think at this moment, when the virus is very much still in the community, so to speak, it would be reasonable to wear the mask as well when walking and running. Regarding the second part of this question, how probable is it to contract the virus walking through a space? It's been studied, the virus at least does stay in the air for at least a couple hours, but whether or not that's enough of the virus to actually cause infection, we just don't know yet. I don't believe there's any evidence that it clings to hair. It does get on the soles of people's shoe. That was found for people that came out of a hospital in Boston. It was on the soles of their shoe. I think generally if you're in an outside area, you can have a little bit more latitude to be, maybe not do a mask or not be as tight with the protective gear, but in a closed space, elevator, hallway, staircase would definitely take every precaution.
The last question we have, because we're, I think, nearing our end, is antibody testing and protection. Let's say you have it. Do we know, are you protected if you have antibodies to it?
Yeah,
And I'll give you a reference to New York City, where they tested in the city, and about 21% of individuals in New York City have antibody positive to that. Suggesting that there was quite a bit of COVID-19 going around the city at that time. Upstate New York, it's anywhere from 6 to 17%, so it's less in that area. We've got antibody testing available, but it's not widely available throughout the country at this point in time. I would caution you that we don't yet know whether, if you have an antibody in your blood, whether you're protected from getting COVID-19 a second time or a reinitiation of the virus. So we don't yet know what the best antibodies are that you'll need for protection and how long it will last if you're antibody positive at that time, how long the protection will last. That information is evolving as we talk about it now. The pay for or coverage for that will probably be available through insurance companies and through the government, but I cannot guarantee that at this point in time. Vikram, do you have anything else to say about antibody protection?
No, I think, yeah, I think the only thing I would echo is we don't know yet, and then that doesn't necessarily, I think the WHO came out with something last week saying they're not protective. I think they've followed that up with clarifying, just saying we don't know. I think we're all hopeful that they are, because that would mean a great deal about getting back to, as far as implications for getting back to daily life. But at this point, we know that it means exposure and that they may or may not be protective.
Well, I want to thank everyone for their participation today. I certainly want to thank the participants for all the questions that are very good that they submitted for us for this period of the pandemic of COVID-19. As was shown today on your Johns Hopkins website, we are at 1 million individuals in the US with COVID-19 documented infections, and we're approaching 60,000 people have died from it, which was more than was seen in even the Vietnam War at that time. So it's literally a war with this virus at this time that we're in the midst of, and hopefully as things evolve, we'll get or be able to recommend treatments that will save more people. And at this time, the prevention that was mentioned earlier of distancing is certainly our best protection for people with existing cardiovascular disease who are, for a variety of reasons, at higher risk for succumbing to a complication or death from this disease. So we want to thank everyone. I will be able to now turn this, I think, back to Liz to thank all of our sponsors for the program, which she talked about earlier, and the individuals in Chronic Care Policy Alliance who have arranged for this program. So from me, thank you, everyone, and I'll turn this back to Liz Helms, who is the President and Director of Chronic Care Policy Alliance.
Dr. Baumer and Dr. Tajwani, thank you so much. Dr. Peacock, thank you so much. I know you're not with us, but we are recording this. I want to thank everyone for getting on this call and spending time here. Remember, we will have questions on our website, chroniccarealliance.org/webinar. You can also see the Global Healthy Living Foundation and the Asthma and Allergy Network websites also on this last slide. These slides will be available to you. I know we ran over, but we knew we were recording, and so we wanted to be sure we didn't miss anything. Thank you all. You can continue to send us questions, and we look forward to following up and staying on top of this conversation. We wish you well. We're better together. We will persevere. Thank you so much.